So I worked as a personal trainer for a year as I was like beefing up my resume and CV and all that. And really this was, devastating at the time, but in hindsight, it was the biggest blessing that I ever got.
I love that you specified when you said naturopathic doctor and you're like, it's still a doctor.
During that time though, I was in a car accident. I herniated 2 discs and I had my own chronic pain now. For a period of about 2 years, I couldn't really find a really significant relief for my back pain. It ended my track and field career. It changed the trajectory of my life. A sprain in my iliolumbar ligament and a tear in the fascia of my trap muscle.
Whoa.
The next day he did PRP on me at the conference, and 3 months later I was pain-free. What are people in chronic pain trying to do?
Build and repair tissue.
Yep. There we go.
We're such good students.
The goal here is let's open up the highway such that the peptide can actually get delivered to the area that we want it to.
Welcome to the show, Drew. We're so excited to have you today.
Thanks for having me. I'm excited to be here.
Oh my gosh, we've got a lot of energy in the studio today, so it's a really interesting energy, but I'm loving it, and we're excited to have you here, and we would love to know a little bit more about you before we dive into the meat and potatoes of all of these topics that we want to cover, and we're going to try to get through this all because there's a lot that we're really excited to chat with you about. So maybe tell us a little bit about your background, your education, what it is you're doing now, and why you're so passionate about it.
Sounds good. So my name is Drew Timmermans. I'm a naturopathic doctor. Which for those who aren't familiar, a naturopathic doctor still goes through 4 years of med school. We go to a different med school. We go to naturopathic med school. And from there, some people will specialize into different areas of medicine, where the direction that I chose to go was chronic pain management, regenerative medicine, regenerative injection therapy, things like that. But I originally grew up in Canada. So I'm from Southwestern Ontario. You might hear the accent at some point come out a little
Can't
bit.
wait. Come out.
Yes.
Commute.
But I moved out to Arizona to go to med school in 2013. Met my wife out here, opened a practice, did residency out here, and just really never left. And so what I specialize in and what I love doing is helping people who are suffering with acute or chronic pain, especially the people who have kind of been told, there's nothing really that we can do. It's either just wait for surgery, or here's some opiates, or here's some anti-inflammatory medications, go to physical therapy, and they're just kind of left feeling like they're not really getting anywhere and they're still just suffering, and they're told to just deal with it. So that's kind of the area that I love to focus on and help people with.
I love that you specified when you said naturopathic doctor and you're like, it's still a doctor that goes 4 years of school, because I think when people hear something like naturopathic or holistic, it's kind of like set aside in this other category that's like a little bit woo-woo and not quite as trusted. We've become so focused in our westernized culture on the science, and to be fair, and we've talked about this before in other episodes. Do what?
Science with a capital S.
Right, science with a capital S,
yes.
like this religion, right? And it's done a lot of good for us, right? There's so much that we've developed as a country through the science in medicine that has been incredibly helpful. But there are a lot of ways, there's a lot of ancient wisdom that's been lost in the mix of that. And so as a result, I think, again, when you hear some people, when they hear naturopathic, holistic, those kinds of things, it's kind of like, oh, but they're not like a real doctor, right? So I love that you specifically were like, hey, still like went to this school, still have all this knowledge and learning. And me personally, I'm always a big fan of anything that's sort of like alternative a little bit, because I think it's really important that we have this holistic approach and the way that we approach our healthcare. And it's so important. One of the reasons that we do this podcast at all is because in this age, people really need to advocate for themselves, right? There's so much information out there, which can be a great thing, but it can also be a little bit damaging as well, right?
Yes, it can.
And so thank you for taking the time to come on and chat with us. Derek, where do you want to get started on this?
Man, there's so many different directions we can go. So chronic pain was the main, you said is your main focus. What did you say the second one was again?
Acute pain. So just
Acute,
basically anybody in pain. Really, that's,
in pain.
Those are the only patients that I work with. If somebody does not have some form of chronic pain as their primary issue, and that chronic pain has to be more of an orthopedic thing. So if this is like rheumatoid arthritis or something autoimmune in that sense, then that's not going to be my wheelhouse. But if it's, chronic back pain, chronic knee pain, rotator cuff tear, things like that, that's where I'm really going to specialize.
Can I ask, I want to ask though, just real quickly, Why chronic pain? Like, what is it that like made you lead into this specific area of focus? Because my guess is, with your degree, you had a lot of options available to you on where you wanted to take your learning and like shape your expertise. So why pain?
Yeah, it's a good question. So my original plan, so up in Canada, naturopathic doctors, so in Ontario, they're still licensed, so still physicians, all that stuff. But it's not as big of a profession there. And in Canada, we don't have DOs. So out here in the States, you have an osteopathic doctor, right? You can go MD or DO route, and you can basically end up at the same place. You could be a cardiologist, a surgeon, whatever you want to do. In Canada, we don't have that. In Canada, it's just MD, and then you've got ND, and you've got, now you're starting to get your nurse practitioners and that type of stuff.
Interesting.
And so initially when I've wanted to do medicine since high school, but then I didn't know that there was anything other than MD. And so I really had an interest in the cardiovascular system. And so in undergrad, I did some shadowing with a cardiovascular surgeon, saw an open heart surgery, which was the wildest thing.
I cannot even imagine.
And it was super cool because I got to stand at where the anesthesiologist stands, which is at the head of the patient, on a stool, basically almost looking over down into an open chest cavity.
That's
crazy. It was so cool.
It's crazy.
But I saw that surgery and I was like, you know what? Like that is a medical marvel, but it didn't really like get me going.
Yeah.
And so I still knew I wanted to do medicine, and I was an athlete. I ran track and field predominantly in undergrad. And so I was like, okay, well, I'll just do sports medicine. Like I enjoy physio type stuff. I enjoy athletics, that stuff. So I'll just do sports medicine. So I applied to allopathic med school. So it's MD school up in Canada.
Okay.
Didn't get accepted. I had interviews, didn't get accepted. And so I worked as a personal trainer for a year as I was like beefing up my resume and CV and all that stuff. And really this was, devastating at the time, but in hindsight, it was the biggest like blessing that I ever got. That's because cool. It stopped me from going down that MD path, because I'd be an MD today and I wouldn't be a naturopath. And so during that time though, I was in a car accident. I herniated 2 discs. Oof. And I had my own chronic pain now.
I wondered.
And so for a period of about 2 years, I couldn't really find really significant relief for my back pain. It ended my track and field career. It changed the trajectory of my life for sure. Yeah. And so when I moved out here to Arizona to go to naturopathic med school, I still didn't like really know what I was going to do. I was exploring, some integrative oncology stuff because there's a lot of really interesting stuff there. And then I went to a sports medicine conference out in Florida. At this time, I still had back pain. Go to Florida. At this conference, I got diagnosed by the president of that association. He did a physical exam and an ultrasound evaluation on me. Diagnosed me with something that I had never been diagnosed with, which was a sprain in my iliolumbar ligament, which is a small little ligament in the low back, and a tear in the fascia of my trap muscle.
Whoa.
The next day, he did PRP on me at the conference, and 3 months later, I was pain-free.
Stop.
No joke.
And you'd been dealing with this for years?
Dealing with it, at that time point, it was 2 years, yeah.
Wow.
And so at that point, I was literally like, this is what I'm going to do for the rest of my life.
So
this
cool.
It clicked, it resonated. I loved what PRP was and everything like that. And I have not turned back since.
I'm so glad I asked you that question, because I think I love whenever somebody gets in a specialized field, it's kind of personal, right? I think that the best professionals come out of experiences like that are personal. It gives you an incredible amount of compassion and empathy for your patients, a huge level of understanding, and just passion for your work in general. I mean, even think about even just like personal training. I have a friend, Drew, lives in Hawaii now. I don't know if you've ever heard of the Fit to Fat to Fit guy, and he literally had been a trainer his whole life, but he put on all this weight because he wanted to understand what it was like for his clients, who were 70 pounds overweight, and what it felt like and the cravings, to be able to have empathy. And I'm like, that just makes so much sense to me. And so that popped in my mind when you were talking about it. And I think it's so cool that you have that experience to really drive you in the field that you've chosen, right? And there's so many people that deal with chronic pain, and it's just debilitating. And I can only imagine. I myself have never really had chronic pain like that, so I can't imagine. And especially for you to like be in this position where you're not getting relief, right? And then to go and have this one single experience, not even like meet this doctor, appointment after appointment, scan, x-ray, MRI, whatever it may be. Let's try it, like just literally boom, right? And you said it was as simple as like ultrasound. Like that kind of blows my mind a little bit, because I would assume like x-rays or all these other things need to happen to get, but is just that's just not the case when it comes to diagnosing what's causing pain?
Oh, good question. So this ties into something that I'm extremely passionate about, which is trying to separate out imaging from chronic pain.
Okay.
And imaging is extremely, extremely crucial in a lot of cases, and it was very helpful in my case. But what you have to do is you have to link the imaging with what the patient is saying. And so, for example, in my case, when we did an MRI on me at that time, I had 2 herniated discs. At that time, those discs were not causing me any pain despite having the discs.
Oh, wow.
But because no physician ever did a proper physical exam on me to be able to say, oh, wait a minute, the activities that should aggravate you when you have discogenic pain are not aggravating you. Therefore, those discs are asymptomatic. I was left just being told, well, you have disc herniations, go to PT for a disc issue. Well, I'm going to PT for a disc issue, and it's not helping me because
oh my God,
the thing that's causing me pain is not actually my disc. And so this doc listened to my story. He did a physical exam on me. Then he did the ultrasound imaging, which his approach is really unique in that he's looking for small tears in fascia and ligaments, and that's the stuff that we do now as well. And you could have probably gotten some of that information, at least the iliolumbar ligament, from a good quality MRI. But it's just the fact that we took the imaging and then correlated it over to, okay, but does that match up with the problem?
right.
Because there are lots of people out there who have no back pain and they have herniated discs.
No kidding. I wouldn't have thought that.
We actually had a guest on previously to talk about this, Erson Religioso. I'm butchering his name.
Religioso.
Sorry, dude. But he actually talked about kind of a similar concept where imaging it can be somewhat of a red herring sometimes, where like people get imaged with these herniated discs, and when someone hears the term herniated disc, they're like, oh, that's serious, that's really bad. And then they can do the opposite of, like you're saying, there's cases where they have a herniated disc and there's no back pain. There's other situations where people hear herniated disc and then all of a sudden they not make up, but like all of a sudden they're looking for signs of pain, and it can exacerbate it and make things worse. And an analogy that he used that I really, really liked is he's like, when you do these images and these scannings, a good way to convey it to the patients is it's like internal wrinkles, right? If you see wrinkles on your face, it's not like this terrible thing that's going to end your life, but like it is a sign that there is something underneath, under the hood, that is causing that to be happening, right? And so I don't know if you've got any thoughts on that.
Yeah, I 100% agree with that, and I've had several patients over the years who have catastrophized after the fact, once they learn something. But I think a few things. One is I'm always working on how do I deliver this information, and 2, how do I also convey that we have solutions. I think that's one of the other pieces to this, is that in the conventional medical community, it's okay, you've got a herniated disc, and just wait until it's bad enough and then we'll do surgery. And it's kind of this like, it leaves patients feeling like there's nothing that they can do. There's no empowerment. They can't, change things on their own.
Just waiting for the inevitable.
Yeah. And so I think that mindset that is imparted from the standard medical community has not serviced patients well, such that there's now fear around a herniated disc. I currently have no back pain because of the things that I've done for my back over the years.
Wow.
But if we did an MRI on my back, I would still have 2 herniated discs. They're just not painful.
Right.
Could they become painful in the future? Yes. Will they? They probably will. And I will probably need continued care over the rest of my life for my back. And that's just the cards that I was dealt from that accident. But it's that acceptance that, hey, it's going to happen again. I know what to do because I've gotten to this place. And so there's a lot of psychology around chronic pain as well.
Yeah.
And it's hard to layer that in with patients. Some accept it easier than others. But
can we dive into that a little bit?
Yeah.
Like, because I just had a concept of this kind of popped into my mind, and like we're so lucky that we've talked with so many experts.
Oh my gosh!
I feel like that's kind of what's framing a lot of this. Is I feel like a person's conception of their own pain, right, is largely driven by the sympathetic or the parasympathetic nervous system, right? If you experience pain and your sympathetic nervous system, your fight or flight response is really going crazy, then that's going to just be exacerbated and made even worse. And so, I don't know, maybe you probably know a lot more about this literature than I do, but does that play a part in the perception of pain?
Yeah, it does. And obviously there's a tipping point, right? You think of the example of, you have a home invader and your adrenaline is now through the roof and you get
Pain
attacked.
is blunted.
You're probably not going to feel any pain
Right.
because, your sympathetic nervous system is so on overdrive. But removing that situation, when you look at this like chronic, just like overactivity of the nervous system and the sympathetic nervous system, you do get amplification of pain in the brain. And what's important to remember is that pain is a perception by the brain. Pain is the body saying this stimulus that I have, which usually is in the form of something, sharp or something that's actually a danger signal, is getting interpreted as pain. And then it's a way for your brain to tell you, hey, probably don't do this thing. This thing is probably not smart for your survival.
Yeah.
But what can happen is we can get changes in the brain that are resulting in more normal stimuli being perceived as pain. And so, patients with low back pain may just have muscle tightness from dehydration and electrolyte imbalances like a magnesium deficiency or something like that. And the brain can take those signals that should be perceived as tightness, and the brain can actually go, no, we believe that's pain. And so now somebody has chronic back pain, and it could be something as simple as you just need to hydrate and you need to take an electrolyte supplement. And we've helped a lot of people with their back pain simply just because of that.
Wow.
And so, and part of that process is often with the sympathetic nervous system. And so when you can start to even calm that down, we can sometimes see this reduction and this amplification that's happening. And it's difficult to deal with, though.
That's incredible. Yeah, I think you broke that down very well. You mentioned a specific treatment option, PRP. I want to dive into that, but before we do, I kind of want to talk about a little bit about like the podcast we just got off of, or that we just did, the last one. Dr. David Bilstrom, he talked about how, and I think a lot of our guests talk about this, and it sounds like you're talking about this as well, is that in our society there's so many Band-Aids that we put on the problem instead of addressing the root of the issue. And I think that pain, honestly, there's a couple of epidemics that are happening in this country. The obesity epidemic is one of them. Another one is the opioid epidemic, right? The fact that there's so many people that are on opiates and are overdosing on opiates, I think, really shows that we have a problem with pain. And that really, like, masking the pain is not going to be fixing anything. And so using that to kind of frame this question, tell us a little bit more about PRP treatments and why this is a better option than your run-of-the-mill painkillers. And maybe we can talk a little bit about like ibuprofen, acetaminophen, all those kind of things.
Yeah, so PRP is an acronym that stands for platelet-rich plasma. So it's a process where we draw somebody's blood, we then spin it in a centrifuge, and we extract out this, or I should say concentrate, and then extract out this layer of plasma that is very rich in platelets. Platelets are these little cell fragments that contain growth factors and other signaling molecules that are normally released when we have an injury. So if you cut yourself, you break a bone, you injure a tendon, whatever it is, one of the things that's going to happen is these platelets are going to release their growth factors into the area, and that starts a chemical cascade to call resources into that area, and also to start to form a clot to stop bleeding and all that type of stuff. And so about 25-ish years ago, some physicians discovered that, hey, we could take these platelets and we could inject them into an area that is chronically damaged, not acutely damaged. And they seem to have kind of the same effect where they will what's called degranulate, or they will release their growth factors on the inside, and they will now start a new healing process. So the way that we think about this is we're creating a new injury response without a new injury. And so, for example, if we're doing this in a rotator cuff that has a tear in it, we're not making the tear bigger in order for the body to go heal that tear. We're putting in the signals to say, go try to heal this tear. And so the reason that it can be so much more beneficial than ibuprofen, Tylenol, your opiates, even steroid injections, is because we're actually supporting the body to do what it can do and what it knows how to do through design, right? It is to try to heal something. It's to use these growth factors to signal stem cells and resident progenitor cells in the area, which are going to contribute to the healing process so that we reduce inflammation and that tissue becomes less sensitized to pain. And you can regain range of motion, you can regain function, and ultimately what most people want is a reduction in pain.
That makes a lot of sense to me.
Yeah.
What other kinds of treatments, is like PRP what you're primarily using to treat these kind of chronic pain conditions, or what are some of the other avenues that you take to address these?
Yeah, so the core of what I do are the what we call orthobiologics, which includes the PRP, platelet-rich plasma. It includes stem cell therapy, and that comes from the patient. So things like bone marrow and fat tissue or adipose tissue. Both of those contain a rich source of stem cells that we can then use to re-inject that back into an area and stimulate the same thing, just to a much stronger degree. But then because of my naturopathic training, we're still also talking with patients about nutrition, about sleep. There's different supplements, there's different peptides. We're huge advocates for proper physical therapy and strength training, because most people are their tissues are just not strong enough, and so their joints are taking a beating.
Right.
And you get them in with a proper physical therapist and or a good strength coach, and I mean, pain can get a lot better just from stabilizing the muscles around a joint, as an example.
I want to make a shout out real quick to
Yeah.
Dr. Tom Walters, a previous guest who wrote this massive book.
Oh yeah, it was super cool.
That was just like for
An
people
encyclopedia.
An encyclopedia of essentially, like, if you can't get a hold of a good physical therapist, this is everything that the patient with layman's knowledge needs to know in order to assess and essentially treat their own pain and the exercises. It absolutely
awesome.
Phenomenal. So like we'll put a link up there and like please check that out.
Yeah.
Awesome.
Yeah.
So those are the things that we use.
That's amazing. So I love that you covered kind of the whole gambit. One of the things that you talked about, and specifically, was the using nutrition to impact healing and pain and all that. Is there specific diets for different injuries like that can help with injury recovery more than others? So, like, for example, if I do something to a tendon or a ligament, is protein more important versus if I break a bone, do I need to be loading up on drinking more milk or getting more calcium? Not the milk with the calcium misnomer. or are there other things along those lines?
Yeah, good question. I am relatively agnostic to diet.
Okay.
With the exception of just anything but the standard American diet.
Gotcha.
So,
the sad. Yes.
Yeah, yes. And with some core principles in there. So protein consumption is, I think, very, very underestimated in its ability to have an impact on tissue healing and chronic pain. And I think most people are even dosing it too low when they're trying to do a high protein diet. And so barring anybody having any, major kidney or cardiac issues where they've been told by their physician to restrict protein, we are often trying to push protein upwards of kind of 0.8 to 1 gram per pound of body weight.
Yeah, it's a lot.
And honestly, that's kind of the standard bodybuilding recommendation.
Right.
Yeah. And what are bodybuilders trying to do? They're trying to build and repair tissue. What are people in chronic pain trying to do?
Build and repair tissue.
Yep. There we go.
We're such good students.
I have taken a lot from that community because their goals are the same.
Yeah.
The goals are the same. The end outcome is trying to be different, right? But the goals are the same, which is to repair and rebuild tissue as much as physically possible. And so, getting a gram per pound of body weight is tough. It is tough for people. A lot of our patients are coming in and, there may be, let's say you've got a 140-pound female and she's struggling to get like 60 grams in a day. Yeah. And so getting that to 140 is tough, so as long as we can ratchet it up and just work towards it, fantastic. Now
that's better.
I have a tiered system that I'll use for this. The best thing possible is whole foods. So if you can eat a burger, you can eat chicken breast, you can eat, salmon, whatever it is, and as wild caught and sustainably farmed and pasture raised as possible, that's what we're going to go for. If someone is struggling there, and let's say this 140-pound woman is only able to get 80 grams from whole food sources, then I'm okay adding in some form of a protein shake, right? Whether that's if they tolerate dairy, then I'm fine with a whey protein shake. If not, we might look at a vegan plant-based protein, or there's bone broth proteins that as well that are going to have complete amino acid profiles that we'll use. And then if that's still hard, because again, those can also, a whey protein shake where you're getting 30 grams is filling for a lot of people.
Yeah.
And so if we're still struggling there, then what we'll do is we'll actually just add in essential amino acids. And so we'll use powdered form of EAAs. We add that on top of meals. There's actually some really good literature showing that in certain patient populations, this is more in the trauma and post-surgical patient population, but doing that can actually help to reduce muscle wasting and stuff like that after somebody has a knee replacement. So It's proof of concept that, hey, if you take these essential amino acids and you add them into the diet on top of a meal, you're getting the stimulus for mTOR, which is this signaling molecule that helps to create growth and repair. And then you have the building blocks from the food and the amino acids from the essential amino acids, and that's helping to stimulate tissue repair.
Hey, I hope you're enjoying today's podcast. I just wanted to take a quick break because if you're listening, you probably know what we do here at Invigor Medical Podcast, but maybe not what we do at invigormedical.com. So let me introduce us. At Invigor, we provide prescription strength treatments and peptides for weight loss, sexual health, and lifestyle optimization. Every treatment plan is carefully prescribed by licensed doctors and sourced from legitimate pharmacies. You don't ever need to buy questionable research chemicals again. And bonus, as a podcast listener, you get a 10% discount on your first treatment plan with code podcast10 at invigormedical.com. Now, let's get back to today's episode.
So protein is huge, number one, and then just moving away from just processed food. So box, bags, all that stuff, more fruit, more veggies, more protein, more grains, more fiber. Some people are going to do best on a carnivore diet. Some people are going to do best on keto. Some people are going to do best on plant-based. It's so hit or miss in terms of just giving a blanket statement that I try to really stick to core principles, which is just less processed food, more food found in nature, and a big emphasis on protein consumption.
I think it was Michael Pollan who said this in his book, In the Defense of Food, which is absolutely phenomenal. But he essentially boiled it down to this: eat food. What is it? In moderation, mostly plants, something along those lines. So it's a very simple, straightforward, but just eat real food, something your grandma would recognize or your great grandma would recognize. In moderation, mostly plants, and you'll probably be fine. I guess the carnivores would disagree with the mostly plants part, but so. I've got a couple of places. I just don't want to dominate the conversation.
No, it's okay. I feel like I dominated with our last recording, so it's kind of fair to let you take the reins a little bit. I'm happy to let you.
Great. So I there's a lot of different things, and there's one that I feel like you might actually have some insight on. So PRP, I think that's super fascinating for the treatment of pain, and the fact that it's targeted, right? That they're able to get to this point where you have an injury. There's a more controversial peptide, and maybe we can just touch on it briefly. I know that the FDA has really cracked down on this, but I think it's probably I think you probably know more about this, whether the jury's out on it and the FDA is just wanting to make sure that it's like 100% safe. But BPC-157, it's a peptide, the healing factor peptide. I've heard people refer to it as the Wolverine peptide because it like stimulates growth so quickly. What are
somebody in marketing came up with that name?
Yeah, seriously.
Yes.
What are your thoughts on BPC-157?
Yeah, so a lot. I've been using. Let's see. My introduction to peptides, going back to our earlier discussion, was when I had that chronic pain.
Yeah.
So before I moved from Canada to the U.S. for med school, I was looking for options for improving my back pain, and I came across peptide therapy. At that time point, I don't even think you could get it at a compounding pharmacy. It was all underground stuff, and so.
So was it like research chemical stuff?
Yep, all research chemical stuff at that time.
Man.
And so I took a big risk. Thankfully, it worked out. I didn't have any major negative issues. But at that time point, I got exposed to BPC. I got exposed to the growth hormone secretagogue, so CJC 1295 without drug affinity complex, the ipamorelin,
Samorelin.
but Samorelin was definitely talked about, and then PEG-MGF, a few of the other IGF-1 stuff. So I kind of got exposed to a lot of them at that time, and BPC was one of the main ones in addition to the growth hormone secretagogues. And so, I experimented with it personally back then. This would have been 2011, 2012. And then after, PRP helped my back and stuff, it kind of fell off for a bit. But then when I started in practice, so in 2017, is when I really started to use it a lot again with patients, because we now had access to it through a compounding pharmacy, and I was clinically seeing patients. And so we've been using it in patients now for 7 years, and I have seen some really, really wild things with BPC.
Yeah. I mean, can you share a couple of those experiences? Obviously, don't want to disclose too much information about your patients, but
yeah, there's two that I want to share that are like the core ones that I share. And simply and they're not necessarily orthopedic, but it just goes to show how amazing this peptide can be. So we had this one patient who he had a rotator cuff tear, and he wanted to try BPC-157. At this time, we were predominantly using injectable, and so we did the injectable route. And about 8 weeks later, we talked to him and asked him how his shoulder's doing, and he's like, oh yeah, it's about 50, 60% better since starting it, which is fantastic in and of its own. And he goes, but what's weird? He's like, I had this fungal infection on my toenail. I dropped some weights on it at the gym like 3 years ago, and I had this fungal infection that just never went away. And he had tried everything according to him. He had tried all the over-the-counter stuff. He had tried all the meds from the MDs. He had tried everything. And within about 4 weeks of BPC, it was 100% gone.
What?
And
That's crazy.
I didn't even know that he had this. Because again, he had just accepted that, I've got this and it's never going away. And he started on BPC and it went away, in addition to his shoulder getting better.
That's crazy.
And so that's one that's just okay, that it's just crazy. And then we had another patient. So BPC, I only use it for orthopedic stuff because my patients are only really orthopedic. But it does also help gut tissue a lot. And so I had this patient early in practice who also had a stomach ulcer that was refractory to all forms of treatment. And this dude was suffering in misery, in so much pain, and all allopathic meds had failed. He had tried, everything under the sun that I knew of for trying to help heal that gut lining. And we tried BPC, and within 4 weeks, he was pain-free, and it was gone.
Well, and so BPC-157, kind of where it comes from, is actually from the gastric juices, right? I think I remember
gastric juices. So what a phrase!
Here we are. I'm mentioning Huberman now.
There we go.
He recently just released an episode about peptides, and he really went into great depth about, like, apparently back when they first discovered this, they would take, if somebody's like something got a digit got chopped off or something, they would literally take people's stomach acid and put these severed joints or whatever they were in stomach acid.
What?
And then when they reattach them, they would regenerate so quickly because it kind of makes sense. Like when you think about the stomach, it's such a I wouldn't say hostile, but I don't think that's the right word. But it's a very acidic environment, right? It's very potent, and so if there's any injuries there, the body needs to be able to heal very quickly. And so BPC-157 being in those stomach acids makes sense. And so basically, that's those factors kind of like accelerating that healing is pretty incredible.
And that's one of the reasons that BPC-157 is one of the only peptides that is bioavailable orally. And in a really good fashion as well. Most of the other ones are not because the peptides are going to get broken down by the stomach acid and
interesting
proteolytic enzymes and things like that. But BPC doesn't because
it just joins the party.
The parent peptide is naturally found in the stomach.
The parent peptide.
I was just going to ask one more question, and maybe you're going here, but like, why is the FDA cracking down on it so hard?
Good question.
Yeah.
I'm holding back what I was going to say. Probably nothing to do with money.
Oh, nothing.
Oh, 0%. No.
Never.
Yeah.
It's never about money.
No.
That's crazy.
No. So here's the difficult part is, so what the FDA did was they put the bulk raw substance on a special list that essentially says compounding pharmacies, you're not allowed to make this.
Yeah.
So it's not that they actually went out and made BPC-157 illegal. They just made it such that the people who compound it can't legally buy it. And this has happened other times before with non-peptides. You know, like several years ago, there was there's some different IV ingredients that can be used in advanced cancer cases, chronic infections, chronic disease that were kind of in this also area where they had not been officially approved by the FDA, but also never made illegal by the FDA. But basically, the FDA came out and said, you know what, we're going to say that you can't make this anymore. And then within a few years, what happens is a pharmaceutical company came out with a version. And thymosin alpha-1, which thymosin alpha-1 is one of the best peptides out there for immune issues. We used so much of it during COVID because of how well it worked for patients. Thymosin alpha-1 is very similar to thymosin beta-4. They both come from the thymus gland. That's why thymosin beta-4 also has a little bit of immune function activity. But thymosin alpha-1 was actually an approved medication in Europe as the peptide, the exact same peptide that we're all getting from compounding pharmacies, approved in Europe, but didn't get approved in the US. So it then got made by compounding pharmacies. But then when COVID started happening and everybody was really using thymosin alpha-1 and LL37 together for COVID, what happened then was the FDA goes, wait a minute, we're going to add this to this list. And now there is a pharmaceutical version. And it's about 10 times the cost.
I feel like there is a lot of stigma around peptides. You know, like people hear peptides and they hear, and I think part of it is honestly the names. You get names like PT141, CJC157, BPC157.
It sounds very mad scientist.
Very exactly. But like when you actually consider that peptides have been in use treating patients for decades. Like I think the first instance of it that I can think of is just insulin. Like treating people with insulin. Insulin is literally a peptide that we are treating diabetics, and it's a life-saving thing. Another very big mainstream medication that's a peptide. That is literally a peptide. Is semaglutide, Wegovy, Ozempic, Zepbound, which is tirzepatide. Like these are all peptides that are in common use. But yeah, I mean, you put the medication label on it, and all of a sudden you can charge thousands more dollars to get the I don't know. It's a whole thing. That is an entirely different topic that we could probably go down on a different podcast.
Different rabbit hole. Yeah, for sure. We do live a good rabbit hole.
Yeah.
I was thinking about when you were talking about injections with the
BPC.
BPC
157.
157.
That's it.
I wanted to say 141. I think it's like the name of a robot in one of my kids' shows. something 141.
PT 141.
That's something else. Oh no, I'm thinking of BB 114 on Star Wars. My kid has he's got it's like his little robot like protector buddy at night.
Oh, BB-8. Huh? BB-8. Is it the circle
114? Yeah, 114. Whatever. I don't remember the names. I like the movies and I follow the story, but names gone. Don't remember those. That's not important enough for me to keep track of. But anyway, when you were talking about injections and like thinking about how he tore his rotator cuff, right, or whatever, but then he's got like this toe fungus that's also being healed. But I was thinking about injections. And I think we talked about this a little bit before we recorded as well, as far as like, but I think this relates to PRP when it comes to
the locality.
The location of the injection. And is it important that it's like in the injury itself? Because I'm like thinking like shoulder, but toe fungus, and how does that relate? Like, there's a lot rolling over in here, but maybe we could address that and talk about does that matter where injection is happening, whether it's the peptide or whether it's the PRP or whatever it is.
Yes. Happy to go on this rant because this is a huge pet peeve of mine. The biggest piece of bro science in peptides is that it has to be injected over the area of pain in order for it to be effective. And it's complete bullshit.
Yeah.
So, so there's a difference between a sub-Q injection and a direct injection into the damaged tissue. So if we have, I'm going to use my credit card here. If all of this area here, if this is skin and this is all the subcutaneous tissue where we do a subcutaneous injection, this layer here represents the fascia over top of a muscle, a tendon, a ligament, a joint, whatever it is.
So if you're just listening, he's got his credit card. We've got above the credit card is the subcutaneous tissue. And then here, the line of the credit card is the fascia. And then underneath of that is the muscle.
Perfect. Yes.
Right? Okay.
Yes. So if we do an injection into that subcutaneous tissue above the fascia or above the credit card in this example, that fascia is there to prevent things from invading deeper than they should, because it's actually a protective mechanism of our body to prevent infections from spreading. You get a cut in your skin, the last thing you want is that cut going into your muscle, which could then go into your bone, which could then go into your central nervous system. And so when you do an injection into that subcutaneous tissue, it does not pass through that fascia.
Okay.
The way that the peptide gets to the rest of your body is there are blood vessels and lymphatic vessels in the adipose tissue, in the subcutaneous tissue, that absorb those peptides such that they then get distributed throughout the whole body via your blood system.
Okay.
That's how when we do a subcutaneous injection of insulin, as an example, going back to a very classic example, you do a subcutaneous injection of insulin, you're not just giving insulin to your stomach fat, you're giving insulin to your whole body.
That makes so much sense.
Yeah.
What a great correlation to draw. Actually, now that you're saying it out loud, I hadn't really thought about it before, and I didn't, the bro science or the insulin, but like as soon as you said that, I'm like, obviously. That makes so much sense.
While we're on this topic, you're still
He's
on
still
your
on
rant.
his soapbox.
You're still on your
I'm
rant.
still on the soapbox.
Let me know when you get down.
Let him cook.
So when we then do a targeted injection deep to the fascia under ultrasound or x-ray guidance, like I do in my clinic with PRP, that is different. And I believe there may be additional beneficial effects if a doctor under ultrasound puts BPC-157 inside of a knee joint. That may actually be more beneficial than doing a subcutaneous injection because you can get higher values. But if you just do it subcutaneous over the knee, that is not going from the subcutaneous tissue through the fascia, through the muscle, through the joint capsule, into the joint. It's just not going to get there. It physically doesn't.
It's the Wolverine peptide, not the Juggernaut peptide.
That's pretty good. I like that.
Whew, I am
like
on it
that.
today.
You're
It's all
on
the
a
caffeine.
roll.
I really am.
Well, so the question I was going to ask is, and this is just general, this is kind of just general education, but it ties to what you're saying, is there anything that people can do? Because like a lot of the treatments that we offer are subcutaneous injections. Mm-hmm. Is there anything that people can do to make sure that the subcutaneous injections that they're administering to themselves are as effective as possible? Like, or is it just like really as simple as just pinch, inject, and you're done?
Pinch, inject, and you're done is more than sufficient in my opinion.
Awesome.
Now, if we wanted to enhance that, which I think could be beneficial for some people, is getting blood flow to the area that you want that peptide to go. So as an example, if you have a tear in your meniscus in your knee, that meniscus is not very well vascularized. And so at rest, there's really not a ton of blood flow to that meniscus. Mm-hmm. And so if you had no blood flow to the meniscus and you do a subcutaneous injection of a peptide like BPC, then it might not get there, or it might get there in such small amounts because there's not a ton of blood flow going to that area. A labrum, a labrum is going to be another example, or just most tendons and ligaments. But if you went and you did some form of light activity or exercise as an active modality, or even if you did something as a passive modality, such as a sauna session, some infrared light therapy, pulse electromagnetic frequency pad, something that helps to vasodilate. We actually will also sometimes use tadalafil. We'll just use a good old tadalafil, 2.5, 5 milligrams in conjunction with the peptides in order to improve vasodilation. And for the people who don't want a medication or can't take a medication, just a good quality beet juice supplement can be really helpful. But the goal here is let's open up the highway such that the peptide can actually get delivered to the area that we want it to. Now,
that makes a lot of sense.
That doesn't mean it's only going to go there. It's still going to go everywhere. Hence why the example earlier, the guy with the foot fungus got better when he was doing, injections into his belly. Mm-hmm. It will get there eventually. But I think that's one way that we can improve the efficacy. But again, it's not required in order to see benefit. I think it just can add to it.
Yeah. It's an additive effect. I appreciate you going into that. There is something specifically. I don't know how much you know about NAD. So we're on the topic of pain, or just in general, we're talking about pain. And there's something that I've wanted to talk to an expert about for a while, and I think that you'd be the right guy to talk to about this. I've seen some studies that specifically talk about how NAD can help people that are addicted to like opiates and that kind of thing get off of opiates and get off of these addictive things. Can you talk about that and how that works?
I can't really speak to the addictive side and the opiate withdrawal and things like that, because I don't use NAD for that in my clinic. However, where we have been using it is as part of our IV protocols for helping with tissue repair. And that's just because NAD is going to be involved in the kind of like the background process of which our body is going to utilize energy to go through healing processes. And so we'll use NAD, we'll add that into IV bags that have amino acids, vitamins, minerals, that type of stuff, essentially as an additional way to help support the body is ramping through all of these processes that are very, very energy dependent. And NAD is going to be a cofactor for that. And so it just helps to support that process. And then, there's also NAD is going to be involved in the actual DNA repair process specifically and stuff like that. And so we think it's helping in that regard as we are trying to, repair tendons, ligaments, and things like that. And so that's kind of how I will use it. And most of the time we're using it as either a subcutaneous injection, which have you ever had NAD yourself in an IV form?
Personally, I haven't. I've tried the intranasal, but I haven't tried the NAD.
Also, for those of us that are less nerdy, guys, I appreciate that you're nerding out. But can one of you please explain what NAD is?
Actually,
I'm trying to follow with Drew what you're saying. I'm like, okay, I think I'm putting it together, but I can't be the only person listening who doesn't know what we're talking about.
Touch on this just really briefly. Everyone at my office will know if I bring up NAD, I'm going to be asking them about the Krebs cycle, and they're going to cower in fear. They're like, please don't ask me about the Krebs cycle again. So yeah, I'll let you take it away.
What? I don't even Krebs cycle. Don't know what that is either. This is great, guys.
Yeah. So NAD is a form of vitamin B3. So it's one of our B vitamins that is important in how our body is going to shuttle electrons around in the process of making energy. So when we take
ATP.
carbohydrates,
ATP,
fat,
I know that one.
There you go.
In the powerhouse of the cell, the mitochondria.
Yes. Did she just do this?
Yeah, I did.
That was great. I liked it.
Yeah.
And so it will accept electrons and donate electrons in the process of taking carbs, fat, and proteins and turn that into ATP for us to use. Now, that's just one of the functions of NAD. It's also involved in some, as I was mentioning, some different processes specifically for, there's maybe some longevity piece to it, but also in DNA repair, in helping to essentially just repair that DNA.
Yeah.
All right, cool. That was my only question.
Well, that's awesome. Man, so honestly, there's a lot of different directions we can go.
I know, there's so much.
But I guess because I think we're running pretty close to time.
Yeah, we're running pretty close to time.
What would you say if someone is experiencing chronic pain, right? And they don't necessarily have good access to a resource like you. I mean, we're gonna list all of your resources here at the end, so that way they can follow you and they can get good tips. But if someone is going through this, what is your advice to them, and where can they find good treatment?
Oh, the $1 million question. That is I have never fully found a good formalized answer to that yet. And that is just because, some people will ask me if I want a really good physical exam like you do, where, they are, they're going to try to find the source of my pain, what type of doctor do I go to? And I'm like, well, sometimes it's an ND because they'll actually do that and know that. Sometimes it's a naturopath. Sometimes it's an osteopath. Sometimes it's just a physical therapist. It's a thought process on how, on trying to figure out this chronic pain, not necessarily what title somebody has.
Yeah, not specific training, more the way they think and approach things.
Correct. And so one of the things I'll say is that in general, the process of figuring out which tissues are contributing to somebody's pain takes longer than the appointments that insurance provides.
Yeah.
And that's really unfortunate because most people pay a lot of money for their insurance.
Feeling angry again.
It's frustrating to know that, hey, if you're suffering chronic pain and the insurance model is not working, maybe this is a good answer. If you're suffering chronic pain and you've just been seeing doctors through your insurance and you're not getting anywhere, the problem is most likely that you're continuing to see doctors who are in insurance. You have to step outside and go, okay, I understand that this is not working and it's been 5 years and I'm still in pain and nobody has answers for me.
Yeah.
And so you just have to sidestep and go, okay, I'm just not going to see patients. I'm not going to see physicians through my insurance provider. I'm going to go find somebody who doesn't work with insurance because they can give me more time, more attention. And the people who don't take insurance are generally more forward thinking in their thinking.
I think that kind of the point that Natalie was making at the beginning of this, where naturopathic medicine has kind of gotten its bad rep, is that you have to make sure that you find a good practitioner off the insurance path. Because, granted, if you're an insurance doctor, I'm sure that there are lots of good doctors. In fact, I'd dare to say that the majority of them are good doctors. They're just constrained by the system that they're in.
Yeah, very constrained.
But then if you go into the naturopathic side or the non-insurance side, it's a little bit more like the Wild West. You're trying to find a good source, but the systems, our society just isn't built around that. And so I don't know. My intuition is to say, if you're going into that situation, just be careful and doing your research and doing your homework to make sure that you're getting a really good certified person. And like clearly, you've stated that like you've done the time, you've done the research, you've done you've put in the time, and it's very evident in this conversation that we've had that the level of knowledge and passion, it's there.
Yeah.
And so
not just watched a couple YouTube videos and thought, let's give this a try.
Right. Exactly. Yes. Yeah. So on that note, I just wanted to say thank you for joining us and for being such an incredible resource for people that are struggling with this.
Yeah, totally.
Yeah, thanks for having me on. I really, really enjoyed our chat.
And where can people find you and learn from you and learn more about you and the work that you do?
Website. We have a little bit of info. Regenerative Performance. That's the name of our medical practice.com. And then on I'd say YouTube and Instagram are probably the two biggest platforms for me. YouTube's fantastic for people because I think at this point there's probably like 1,500 videos.
Wow.
And YouTube is a great search engine. And so if somebody has ankle pain or somebody wants to learn more about PRP or they want to learn more about BPC-157, you just go to my channel. If you just search Drew Timmermans, you'll find me. Awesome. And then search, and then there's a ton of videos there. So I think probably YouTube is probably the biggest place to, like, if someone really wants to start learning and diving into this stuff and hearing what I've said over the past decade, what I've rambled on.
No, I love it. And thank you for coming and rambling on our show.
Yeah,
it's been a delight. It was fun to have you come in and bring the energy because we were really high energy. So I'm glad you were able to kind of match that. You soapbox. We let you cook. There was a lot of good stuff here.
Lots of great stuff.
Yeah. So Thank you for taking the time to come on with us. It's truly been a pleasure to have you with us today.
Thanks for having me.
Thanks for tuning in to the Invigor Medical Podcast.
If you enjoyed today's episode, you can support us by liking and subscribing.
Your feedback matters, so feel free to share questions or future episode ideas in the comment section.
For more information about our prescription strength treatments for weight loss, ED, and overall wellness, all from qualified doctors and reputable pharmacies, visit us at invigormedical.com. And don't forget to use code PODCAST10 for a 10% discount on your first treatment plan. Until next time, stay well.